Dear Chairman, thank you very much for the introduction. Manos y Manos, thank you very much for inviting me to Athens. I'm happy to be here in this wonderful city. Well, colleagues and friends, now it's about single row. And in 2019, talking about single row is not that common and it's not that easy. And it was a little bit of hard work to figure out why you should still sometimes maybe consider to do a single row repair. Well, it all started with these two guys over there. You might know these. This is Ian Lowe, this is Stephen Burkett. And in 2003, they came up with this paper. And their goals was to bring up a double row repair showing an anatomic footprint reconstruction, showing an increased contact pressure for the repair, with a potentially better healing and better outcomes for the patients. What happens since 2003 shows this slide. If you go into PubMed and you give in double row repair, you find over 370 articles since this time. So there is a tremendous interest within the recent years. And of course, we have to think about why do we have this tremendous interest? Is it someone else who has a maybe higher interest than we do have? Let's discuss this maybe later on. Well, let's go back to the goals of our reconstruction. What are our real goals? What do we want to achieve with our reconstruction? We want a high stability, a high primary stability, that's for sure. We want a minimal displacement during cyclic loading. We want a good footprint coverage, of course, and to optimize our biological healing. It should be easy to perform, that's on the other side, and it should be somehow cost-effective nowadays. This is important. This is from Mochizuki, JBJS 2009, and it shows this little triangle down here. This is the footprint of the supraspinatus. The rest coming all the way around is the infraspinatus covering the greater tuberosity footprint. So this is what we're talking about now. Supraspinatus coverage, infraspinatus coverage. How do we do it best, single or double row? What's going to happen now, I'm going to tell you, Nuno Gomes, my colleague from Portugal, is stand up right here now, and he's going to tell you some things you might have heard before in your life. It's not going to work, it's not going to happen. Single row versus double row. He's going to show you that, of course, footprint coverage is much better. He's going to show you primary stability. It's going to be much better with a double row, higher ultimate loads with a double row, less gap formation with a double row, and again, higher ultimate loads. But, of course, that's the biomechanics, and I already want to capitulate on this. I'm not going to win this fight. Yes, double row can probably do better biomechanically. But now here comes the truth. I'm going to talk again a little bit about biomechanics. We're going to come to the clinical outcomes, and I'm going to show you the downsides, potential downsides of a double row repair. Yes, there is some downsides. If you look at the biomechanics again, and you look at this group from Scott Rodeo, you see that it's not the number and the configuration of the anchors, but it's the number of sutures that makes a high difference. And they say that the single and a double row can be biomechanically equivalent as long as you have the same amount of sutures repairing the rotator cuff. Barber, who did a tremendous job on looking at single and double row, also said that if you have 3 sutures, so a triple loaded suture anchor, this provides an excellent fixation and even better gap formation, less gap formation than a suture bridge technique. A triple loaded anchor provides 100% more stability than a double loaded anchor. Consider this for your repairs if you go for single row. The clinical outcomes, I think this is very important because this is what's going to be told us from our CFOs from clinic if you want to do double row and double row and double row. The clinical outcomes, and this is only the systematic reviews and the meta-analysis of our clinical outcome studies. Meta-analysis from the group from China here, no difference, single versus double row. Peter Millett and his group, and this is only level 1 controlled randomized trials. No detectable difference in outcome scores between single and double row. Yes, there might be a higher retear rate. What this study didn't show and what all the studies didn't show, where were the anchors put? What kind of anchors? Was it a double, a triple loaded anchors for the single row? We don't know this from the study. Where were the anchors placed? Next study, Barber again, 2016. Triple loaded anchor, and this is interesting now, versus a double row reconstruction. Level 1, randomized controlled trial, 20 versus 20, 3 retears per group. No difference in retear by MRI or in clinical outcomes between these 20 per group. And it is more likely to have a type 2 failure doing a double row. What is a type 2 failure? I'm going to show you on the next slide. It's this. This is what it looks like when you are done. This is what it looks like when the patient comes back and is not doing well. And this is what it looks like when you open it up again. It's a retear at the muscular tendinous junction. And this is what we especially know since we are doing these double row repairs. It might be to the compromised blood supply at the medial row. And by doing these double row repairs, we have a high potential because we want to pull the cuff to the lateral side because we have our second row and want to cover the entire footprint. And this might lead to overtensioning of the cuff. And what you can imagine, this is really hard to handle. You can try to do a side-to-side repair. You can put a patch on it. You can put a superior capsule reconstruction. But this is not easy to revise. And most of the times, probably it goes into a reverse shoulder arthroplasty. So this needs to be considered as a big failure. If you look at this study again, they showed that from 46 cases, the retear configuration of a double row in 74% was a medial cuff failure. So all these patients are dealing with these big problems now. You almost don't see this with a single row repair. The next point we have to talk about is the tendon remnant. And this study by Kim is very interesting. And I'm not sure if everyone considers this when he's doing his double row repairs day by day. These guys showed that if this tendon remnant is 10 millimeter or less, and you're performing a double row repair, so over-tensioning because there is tendon missing, then you have a retear rate in a double row of almost 50%, and only 6% if you do a single row repair. So there is room for single row repairs. Look at the tendon remnant. This is important. Let's finally go to the next downside, and we have to talk about costs in 2019. The use of a double row repair can cost $1,000 more than a single row repair per patient you do on a surgery day. What do we gain for this $1,000? And if you look at the clinical studies, it's not really sure what we gain. Is it an economically viable way? We have to discuss this. I'm sure there will be a huge discussion. There is one paper, and I think we need more of these papers. Number needed to treat. How many do we really need to treat with a double row that we win against a single row? On the basis, that's what they say, on the basis of the currently available data, from the cost effectiveness side, there is no room for a double row repair, no matter what size the tear has. Very interesting study, which is brand new. How do we decide how we repair our rotator cuffs? Do we do single row? Do we do double row? Do we use 1 or 2 or 3 anchors? These guys figured out that it depends mainly on the surgeon's training, experience, and inherent practice patterns. So we don't really look that much what's going on the MRI. We just say, well, that's what I've learned, that's how my master does it, and that's how I'm going to do it. Maybe we have to get better here as well. So if you want to perform a single row, how should we perform it? This was the second title. You need a strong anchor, and you need to put it in the medial row. So what they did in former times, they put it all the way laterally, and it was moving all the time. So it goes where the best bone is. It goes on the footprint. Maximize the passes per centimeter, so more sutures, use triple-loaded anchors, use high-strength suture material, provide the best healing environment. Of course, we have to decorticate the bone, we have to microfracture, but no matter what we do, single or double row, of course we have to do this. And this applies also for both repairs, we need a tension-free repair. And this is not always possible with a double row. And this is when you go for single row. Double row and single row have similar improvements in pain and function with equivalent healing rates. This is what this study shows. 2018 OJSM. Take home, if you look at the literature, single row is still an easy and viable way in 2019. In some cases, it's even better than performing a double row. You have less medial cuff failures. Please look at the MRI, look at the tendon remnant. If it's too short, it doesn't make sense to overtension just because you want to do a double row. It is not cost effective if you do a double row just because you can do it. And double row for larger tears. Of course, we're going to hear from Dr. Gomez now why in some cases and in larger tears it is for sure makes sense to use a double row. But still, the biology is probably what we have to discuss more and more about it. Our fixation strength, our stability, our biomechanics are good. We can use triple loaded anchors. But still, biology is going to be the key to reduce our failure rates. Thank you very much.